Okay, today will be hopefully the last session for aortoiliac, so we have to finish it. There's not many questions, so if we finish early, we can ask any question. So any question about aortoiliac disease, just write it down at the end of the session. Hopefully we can answer them. You want to start with this one, Bara? Bara,
Okay.
yeah.
Yes, sure. 67-year-old patient presented with an asymptomatic 5.7 centimeter infrarenal abdominal aortic aneurysm, which is depicted in the CT figure 1 and 2. What other type of arterial aneurysm, when actually present, has the greatest probability of synchronous presentation with concomitant AAA?
يعني شو اعمل لك؟ يعني هاي كلها بس معلومات حقيقة.
Yeah.
عرفت
I think
كيف؟
popliteal is iliac or popliteal.
بتعرف الارقام he needs some numbers عشان زي انتوا رايحين على فحص هلا. إذا عندك aortic aneurysm, what the chance you may have popliteal aneurysm?
15%.
Correct. Thoracic,
Thoracic, I don't know.
very similar. Okay. It's about 10, 15, same things. Okay. So just remember 15, 10, 15 for both thoracic and popliteal. So let's do the opposite. If you have popliteal, what the chance you may have?
Yeah, more than 50%.
Okay, 60%. Okay.
Yeah.
طب إذا عندك femoral, what the chance?
Femoral, I think 80 or 90%.
That's correct. So it's about 80%. عم تدرس كويس يا مرة، كويس في مجال الفحص. طيب. So let's know what's the question. عمل لك فيعمل لك إذا عندك شو السؤال؟ which other aneurysm which usually present has a great probability of synchronized present the يعني which aneurysm إذا لقيتها بكون عندك high chance of you have aortic aneurysm. Which one of these one?
Internal iliac. A, internal iliac aneurysm. B, femoral artery aneurysm.
Well, let's start one by one so we can remember number. What about internal iliac?
My internal, I don't remember.
Well, 5-6%, not very, very low. طيب femoral artery?
Very low. Less than 10%.
هلا تلاقي 80%. ايش رايك على السريع؟
No, if they have femoral, it is the opposite.
Yes.
If they have a
هي ما هي
femoral.
الأوبوزيت. هلا عملوا لك بالسؤال which aneurysm إذا كان موجود يكون عندك height what the chance of aortic aneurysm مو بالعكس.
Oh yes, I understand the question. Yeah. So femoral is the answer.
9% صح؟ يعني بالعكس مو الأورتيك. عندك أنت which aneurysm peripheral تعطيك chance إنه هاي يكون aortic aneurysm. فالفيمورال قديش؟
90.
80 about 80.
Yeah.
popliteal
around 70%. 60, 70.
thoracic قلنا
15, yes. External iliac, very, very rare to have external iliac aneurysm.
Yeah. So matter what the answer would be?
Femoral.
Yeah. Be careful. And that must be popliteal aneurysm because what we used to do. So I have a tricky questions because most people are going to answer with popliteal aneurysm, but really femoral artery aneurysm. If you have it, high chance if you have aortic aneurysms. Okay.
Yes.
But this is number, but it's important for the exam. All these numbers you have, and the vice versa, we talk about it. So you have to remember all these numbers. All right, let's go to Abdullah. You want to answer this next one, Abdullah?
Inshallah, Doctor.
Okay, Allah.
A 71-year-old patient with oxygen-dependent chronic obstructive pulmonary disease and chronic kidney disease has a new discovered asymptomatic 7.4 thoracoabdominal aortic aneurysm. Which of the following etiology is the most likely pathological factor that lead to development of aneurysm in this patient?
طيب يعني شو عم يسألوك بالضبط؟ يعني what is the question؟ شو فهمت منه؟ What do they want?
They want the risk factor.
السؤال. ها؟
They want the risk factor most likely lead to development of pulmonary thoracoabdominal aneurysm in this patient.
طيب so what do you think the most 71 years old? What the most common?
One of them age.
ما هو الage بس شو الباثولوجي؟ شو الباثولوجي؟ What the most common pathology? 70 years old. مو young.
Yes.
Atherosclerosis, right?
Yes.
Atheroma, right? Atherosclerotic disease, correct?
Yes.
اما اذا كنا عم نحكي واحد يانج مثلا 30 40 شو بفكر وقتها؟
Connective tissue disease,
tissue, what
genetic,
else?
Marfan,
Marfan, what else? Aortitis.
Ehlers-Danlos. Yeah,
Yeah, هدول كلهم connective tissue, but what else? And the connective tissue disease one category. What other category?
genetic.
ما هي كلها genetic. Marfan وكلهم دول كلهم genetic one category. Big category, okay? But
Yeah,
next thing, what do you think about young people? Think about aortitis, correct?
yeah, inflammatory.
عندك connective tissue disease, عندك inflammatory arthritis. A lot of things should be called mycotic, صح? And
Yes.
mycotic, you can see it in all people, really. It's not only old, but you can see it, okay? So in this age, 71 years old, what the most common pathology will be?
Most likely atherosclerosis.
Yeah. So that's okay. Simple question. Don't guys, sometimes don't guys too far, and don't think it's a difficult question, or sometimes it's a straightforward question. So because something that you think is too easy to answer, so you say, oh, so you pick up the wrong answer. But it's very simple. So let's see what they're saying here. Let's go one by one.
The cryptogenic aortitis.
Yeah, he's 70. I don't know. If aortitis, he will have it much younger than this one, correct?
Yeah,
I don't think it's any aortitis or arthritis. The first two will not be the right one.
yeah, inflammatory arthritis.
Thank you.
Arthritis. Aortic medial dissection. لا. Medial atherogeneration. This is the most likely, the right answer.
Correct. And the A?
Bacterial wall infection, which is mycotic. No.
I mean, it could possible. It's not the most common. They want the most common.
Yeah.
I think got the answer.
Most common, yes.
Yeah, the most common. Because it could be mycotic. You can have mycotic in any age. But arthritis and connective tissue disease in an early age. So this one most probably is media atherogeneration, which atherosclerotic disease. Again, it's not just straightforward question. It's not much really to argue. It's not like we can discuss about it. Just have to remember these numbers. So, okay, let's go next question. 36. Ahmed, you want to take it, Ahmed?
Okay, Dr. Sam. 65-year-old patient presents with progressive hoarseness and identified to have left true vocal cord palsy, after which the acquisition of computed tomogram detects a large thoracoabdominal aortic aneurysm. Which of the following is the most accurate when describing association with this clinical condition presentation? A.
So before you go, what do you think is, what does he have? Why he has hoarseness?
Thoracoabdominal, usually compression, nerve compression.
Okay, right or left? You think? What nerve is compressed? What's the nerve compressed?
The right recurrent will be on the, under the subclavian, so most probably the left recurrent under the arch. It loops under the arch.
Correct. So the left recurrent nerve loop around the arch. So هيك when you do guys thoracoabdominal, when you dissect, when you put your clamp between the, between which artery and artery, this loop, which part in the arch?
In zone, I think zone 1.
Between the innominate and left common carotid?
Between the left common and left and innominate.
So zone 1.
Zone 1.
No. Push شوي للجنب. Zone 2.
Zone 2? Oh, okay.
You know why? Because I saw it many times. Anytime when you go and clamp proximal to subclavian, it's kind of on subclavian, and you want to clamp, it's very important. When you dissect, you have to see the recurrent nerve. It's big nerve. You can see it moving around. Otherwise, you can injure it with a clamp. Okay? And the reason why we see thoracoabdominal, because it's very close to subclavian. And most thoracoabdominal start in subclavian. It's not like an arch aneurysm. So when it's very important when you put your clamp between the left common carotid and left subclavian, you do two things. First, you cut that. You know what you cut first to release this area? There's a congenital ligament there. What it was patent and closed when we born. You know what's ligament?
PDA, ligamentum arteriosum.
Yeah, ligamentum arteriosum. This is between, because this is patent when we are a fetus. When the moment we born, this will be closed. And this is exactly between the left pulmonary, between the pulmonary artery and the arch, exactly in this area. So when you want to clamp between the left common carotid and left subclavian, you have to cut this ligament. And after you get to release, so you can go around it. And then after that, you're going to see the recurrent nerve. So you have to push it to the side, and then you put your clamp. Okay? If you put it blindly, you can damage the recurrent nerve. All right?
Oh, yeah.
So it is important, guys, if you have to go to this area. All right, so let's say describe this presentation. Let's go one by one.
A, higher rupture risk.
Nothing to do with that because it's nothing, right? Because this is external compression, right? So nothing to do with rupture the aneurysm or not. So if you have a hoarseness, this will not increase the risk of rupture or decrease. Nothing to do with the rupture. It's just external compression of the recurrent nerve by the aneurysm, correct? Okay.
Second, open superior to endovascular repair.
In this area.
Maybe the risk of cutting the nerve is lower in endo, but it will not relieve the compression that is still in the endo. So I don't think it's the correct answer.
Yeah, it's not. There's no difference between open and endovascular. You can have same problems. Yeah.
Yeah.
Permanent.
C, permanent voice impairment.
And what is the cause of this hoarseness? It's a compression, right?
Yes.
So that means the moment you remove the compression, this will come back, right? So they recover because it's just a compression. It's not like a problem with the nerve itself. It's just a compression. So it's not a permanent because the moment you release it, it may take a couple of months. Of course, you're not going to see like next day. It takes about 5-6 months. But like any nerve, like you do any surgery, you do like thyroid, you do like cavity tumor, and you dissect the hypoglossal nerve or vagus nerve. They may have some hoarseness. They have this dysphagia, but all this be temporary because it's just because mobilize the nerve.
Yeah.
So as far you didn't cut the nerve, or there's no problem with the nerve itself, or be temporary. So the moment you release the pressure from the aneurysm and you fix it, the voice will come back, but it takes 5-6 months. But will come back. Yeah. Next one.
The extrinsic nerve compression, correct.
Yes.
And then bicuspid mitral valve. This is a cause of aneurysm, but
it's not nothing to do with the hoarseness. The idea كلها إنه عندك hoarseness with the thoracoabdominal aortic aneurysm. This is the question. If you have a hoarseness plus thoracoabdominal aortic aneurysm, is any of these correct?
The extrinsic.
Yeah, nerve compression. So it's the answer. But this will not increase your rupture risk. Okay. Open and endovascular doesn't matter really. It's the same. Permanent is not a permanent, and bicuspid mitral valve nothing to do with the hoarseness. If you have a bicuspid mitral valve, you're associated with a dissection, correct? Usually aortic dissection. These are just what they noticed. So it's nothing about it, Okay, any question about this part?
Yes, clear.
Yeah, I mean, again, it's just the questions, All right. Today's all questions like exam questions, not like something we can discuss much about them. Okay, let's go to 37. Go back to you, Barra.
Yes, Dr. Samer.
Yeah, let's go to this question.
So 75-year-old patient present with 5.6 centimeter type 4 degenerative thoracoabdominal aortic aneurysm. The patient is current smoker, has an ejection fraction of 45, stage 3A chronic kidney disease, and forced expiratory volume in the first second, that is 50% of predicted. Preoperative imaging determines that the patient is not an anatomical candidate for complex endovascular repair. Which of the following statement is the most appropriate when considering open repair in this patient?
Okay, well, let's go one by one first. He's 75, it's 5.6 type 4, thoracoabdominal aortic aneurysm, degenerative thoracoabdominal aortic aneurysm. So we're not talking about mycotic, we're not talking about sacral aneurysm, Talking about regular aneurysm, 5.6 type 4. Okay? The problem, he has a bad ejection fraction, 40. It's not bad, it's a bit lower. Okay? And the chronic renal disease, and the lung problems, Okay, so you have like 3 organs damaged: heart, lung, and kidneys. And he's not candidate for open, for endo. So you have to do an open. So would you do open in this guy? 5.6. Well, let's go back. Let me ask you a different question. What size of structural aortic aneurysm we start to repair?
For
Or the
type
size?
4, for type 4, 5.6 is
All of
indicated.
them. All of them, thoracoabdominal. Huh?
Yeah, for thoracic aneurysm, it is 6 centimeter, and for
Correct.
thoracoabdominal, 5.5 is indicated for repair.
5.5, so thoracoabdominal.
Yeah, especially type 4.
What? Type 4. What's type 4?
Type 4 from the renal up to the iliac.
Renal to the iliac. This is not
Yeah.
thoracoabdominal. This is infrarenal or juxtarenal. Correct?
Yeah, from the, I mean, from the visceral segment down to the iliac, to the aortic bifurcation.
Okay. But it's supraceliac.
Yes.
Okay. In general, I mean, when you have thoracoabdominal, you have to look at the 2 components: the thoracic and abdomen. Thoracic is usually 6, abdomen is usually 5.6. Okay. But this is correct. So if he has an abdominal component more than 5.5, you can think to fix it. If the thoracic part is the biggest one, then you have to go with the size thoracic. But the question is that this is the size to start doing it, right? Do we have any data to tell us like it's really this is the size we have to do it, or this is just like consensus? Do you have
Maybe
any trial? Do you
I
have
am
any
not
trial?
aware. I am not
No.
aware about any trial.
Right.
But,
So it's different from infrarenal. Infrarenal, we have a very strong data, correct? For
Yes.
thoracoabdominal and thoracic, we have like consensus, right?
Yes.
So that means it's a space for you to think about it. Does it worth it to do it or not? Because we cannot. That doesn't mean that if you do it, it's right. If you don't do it, it's wrong. Even if you go to the guidelines, always the level of the evidence will be like C, B or C maximum. Okay, so the weak recommendations. So at this time, you look at the patient. Like this patient, the aneurysm is the borderline, but look at that. He has a bad heart, bad lung, and bad kidney. Correct. And so the best way if you do endovascular, but he's not good for endovascular. So what do you do on open this guy?
Open is risky also for this wave, very high risk.
Yes, very risky, right? For 5.6, which is the risk of rupture is very low, or say maybe less than 5%, So why you put him through major surgery with bad lung, bad heart, bad kidney for 5.6 aneurysm? Even 6, I may think twice about it. It's 6.5, 7, 8, yes. But 5.6, even to 6, I will think about it. 6.5 and above, I think maybe need to be fixed, even if he's like, because the risk of rupture goes too high. But 5.6, I think it has to be for like good candidate patient, like an asymptomatic aneurysm. If you want to do it, it has to be a good candidate patient with very low risk. So if you decide to do 5.6 type 4 thoracoabdominal aortic aneurysm, it has to be either endovascular, easy endovascular, not complicated, or easy and open. All right?
Okay, yes.
All right. Well, let's go through the question now.
60% of thoracoabdominal aneurysm are associated with medial degeneration. I think more than 60%.
Yeah, the majority are atheroma, right? So it's about maybe 80%. Yeah. Okay.
Open repair is not indicated at the current size. Maybe this one correct?
Yeah, because of his age and because what happened, comorbidity,
Yes.
Okay.
C, aneurysmal growth rate are similar in smoker and non-smokers. No, it is more in smokers.
Right.
There is a 50% probability of synchronous aneurysm.
Yeah. We mentioned that if you have an aneurysm in the aorta, to have an aneurysm in other part of the aorta is only 10-15%, right? We mentioned that before. So this is wrong. Okay.
And the annual rupture risk without repair is 10%. It is less for 5.6, less than 10.
Yeah. Yeah. It's like around what?
It is
7,
around
8?
5. 5.
Yeah,
so
5 or below, even below 5, you know. So it's below 5. But if you take him to surgery, his mortality will be more than 10% for sure. Reason why, you know, I will not do him. Just do serial ultra CT scan. I will go from there. Okay.
Okay.
Any question about this question, guys? Anybody has any question?
Yes, Dr. Samer, regarding retroperitoneal for a high risk patient with lung disease,
Yeah.
is it recommended to go retroperitoneal approach for such a case?
Talk about this thoracoabdominal or talk about infrarenal?
Both thoracoabdominal and infrarenal.
Thoracoabdominal, you have, it doesn't matter because you can't open the chest, correct? So it doesn't make a difference for thoracoabdominal. But most people, they prefer go to peritoneal and do thoracoabdominal because this way all ball will not be in front of you, will not be in your face, will be less chance of edema in the bowel, fluid disturbance, losing fluid. So always when we do thoracoabdominal, it's always better to go retroperitoneal, you know. But if you talk about infrarenal aorta, if you go transabdominal or retroperitoneal, they are the same mortality morbidity. Maybe just the pulmonary complication is a bit lower. That's all. But this is for infrarenal. But for thoracoabdominal, if you go retroperitoneal or intraperitoneal, doesn't matter. But it's better to go retroperitoneal.
Okay.
Any other questions? All right, let's go to Abdullah. Today is easy question today. Abdullah, you want to do this one?
Inshallah. During the conduct of an elective open repair of Crawford extent 2 thoracoabdominal aortic aneurysm, which of the following anatomic structure will be needed to be exposed to facilitate left heart bypass?
Yeah, you see,
Okay.
guys, this question before you go there, this is, you see, somebody has to, you know, for somebody who does open thoracoabdominal. Well, let me ask a question first. What's the difference between left heart bypass and the ECMO?
I think we answered that last week. It is
Right.
arterial, then the ECMO arteriovenous.
Correct. And you need oxygenator, right?
Yeah,
In which one?
in ECMO.
Correct. But in left heart bypass, you just need a machine, right? You don't need
Yes.
oxygenator, correct?
Yes.
All right. So where do you take the blood from? Because you're going to take arterial. Where do you take arterial blood?
From right atrium or inferior pulmonary vein, أقصد.
Correct. Yeah. Now some people they go to the atrium. Yeah, to go to the bandage. You know, the which is the right, left. Not atrium. Bandage. Atrium and the bandage is really تعرفها تطلع هيك bandage.
Yeah.
Band-aid اسمها. The open you can put it there, or you can go to the left inferior. You know, pulmonary vein. To open, you have to open the pericardium. So when you are exposing, you see the pericardium in front of you. So you open pericardium. And when you open pericardium, you can see the inferior and superior pulmonary vein. Usually it takes the inferior pulmonary vein. Okay. Or
Okay.
we already opened the pericardium. Some people, they go to the left atrium. You just put a Stensky clamp on, not on the atrium, on the appendage. You put a Stensky clamp, you put a bursting suture, then you put your cannula inside the left atrium. Or the same for pulmonary vein, you put a bursting suture with a bludget, and then you go through it. The only thing you have to be careful not to do what? Very
I don't know.
important. Air embolism. Because you are open, right? And it's an arterial, it's not a
Okay.
venous. So you can go to the brain and cause a stroke. You know? So you have to be very
Yes.
careful. So when you go there, you fill up the area with a water, with a saline. Okay. So where you are opening, you have your assistant have a saline in his hand and filling up the area with saline, so be no air around you when you go inside. Okay. Or you release the clamp, so the blood coming against you. So the whole year you have to be careful not insert any air embolism. Okay. So this is a proximal, and then the distal, where will be the distal? So you took it now. This is where the blood coming out. Then you bring it back where?
either femoral artery or if we can put it, this is طبعا type 2 in the femoral artery, but we can do it in distal aorta if يعني.
This is correct. Yeah, it depends on what you are dealing, but you can. Most people like to go distal aorta if it's in your way. If it's nice aorta distally, it's much easier. You just put pursing and you put it in the distal aorta. If it's difficult because aneurysm like type 4, as you said, then you have to go to the femoral. All right. Very good. So what the answer for this question?
Inferior pulmonary vein.
Very good. So again, this is like a question for the exam. All right. So let's go next one. Any question about this one? All right, 39. Let's go back to Ahmed. So here, Ahmed.
Hello. A 70-year-old. Yeah.
Okay, go ahead.
A 70-year-old patient presents with 6.5 centimeter thoracoabdominal aortic aneurysm and is evaluated for repair. Which of the following comorbidities is the most strongly associated with an increased risk of postoperative spinal cord ischemia after either open or endovascular repair?
Well, let's talk about endovascular spinal cord ischemia. It's good to talk about it, you know. So let's start first after open. What is the risk factor during open repair for spinal cord ischemia?
For open repair?
Yeah. What is when you get spinal cord ischemia? What do you think you are worried about it? What is the risk factors?
When you have large lumbars.
Correct. Especially which one? Which lumbars we are talking about?
The ones in teeth and T3, T4.
No, T3 is too low, too high.
Or T6 ones.
No, command sac high. Zale. 10
Thoracic
to 12.
abdominal.
10 to 12.
10
Okay.
to 12.
The distal one, the distal. شايفين احنا لما بنحاول نحط مثلا تيفار نحاول نبعد على السيلياك نطلع لفوق دول جنب السيلياك دول اللي بيخوفوا. And T10 to T12, you know. شو اسمه هذا الشريان? What's the name of this artery?
Adamowicz.
Adamowicz, yeah. فهذا yeah, it's always dangerous to go to these areas, you know. So when you are open, okay, so you open and you see a lumbar. Okay, when you decide to reimplant it, well, you just suture it. Do you know?
3 millimeter.
I gave it to you for during surgery, huh?
3 millimeter diameter.
You don't see it; you just see the hole. I mean, yes, you can measure it, but it's not the most important. See something more important. You see a big because I mean, if you do thoracoabdominal, you open the aorta, you open the aneurysm, and in the back, like when you're doing for renal, you see like hole where the lumbars are, correct? And this one of them is Adamowicz, you know. So you're going to see like 3 or 4 of them. Some of them you're going to just put a stitch. Some of them say, no, I need to reimplant this one. How you decide that during surgery?
There are multiple nearby. I can take them in an island. Feasible.
No, what I'm saying, when you decide to do them, and when you decide, no, I just ligate them. When you decide to put an island, when you decide, no, it's too risky to ligate them, let me put an island. When sometimes you say, you look at them, you say, no, it's okay, I just ligate it.
When the subclavian is occluded.
Okay.
Or the patient
this is for endovascular, but for open, it's simple, Ahmed.
Internal iliac?
No. No. You want me to answer or keep talking?
No, question.
Okay. No, you don't know because you don't see it. I mean, you look at the back bleeding. It's like carotid aneurysm, you know, carotid artery. So if you see like lumbars and a lot of bleeding coming from, so you have, you know, it's a lot of collaterals. So you just suture, you just close them. But when you see a big lumbar is open and you see no blood coming out, you know this is an important artery because not good collaterals. You see, the open different from endo because in open you can see. So in endo you cannot. So you have to presume. We talk about the endo. But with an open, you can see because aorta is open. You can see the lumbars, and you look at the lumbars. If I look at the lumbar and see no blood coming out and big lumbars, then I have to reimplant this one. If I see lumbar and a lot of blood coming from this lumbar, then why you need to, adjust suture? Because I know it's good collaterals, because I'm getting a lot of blood coming back. It's like an IMA. The same when you have an IMA. If you have a large IMA, you look. If it's good back from IMA, I don't reimplant it in the graft. But if I see big IMA, I don't see good blood back bleeding, then I reimplant it in the graft. All right? So this is an open repair. This is the way how you decide to reimplant or not. But the risk factor is, again, the more you like it of spinal cord, the more you cover spinal cord, the thoracic aorta, high chance of paraplegia. So it depends. The worst one is type 2, right? Type 2 thoracic aortic aneurysm is the worst one because it's the largest one.
Longest extent.
So when you repair thoracic type 2, this is a high chance of spinal paraplegia, spinal cord ischemia. But the advantage of if open, you can reimplant the internal iliac, so you can decrease the incidence. But the disadvantage, and like hypotension basically during the open repair, a lot of fluid shifting, and all this affect your blood pressure may drop during the procedure because of the pump, because of bleeding. So all this bad factor can affect your spinal cord ischemia. So in open, you have an extra risk factor, which is hypotension and fluid disturbance. But you have something good, you can reimplant the internal iliac. Whereas in endovascular, you don't have this hypotension, you don't have significant blood loss. But the problem, you cannot reimplant the internal iliac, the lumbars. So this is an advantage and disadvantage. This is the reason why in the open, you see mainly is immediate paraplegia. It's more than delayed paraplegia. Because something happened now. Where in the endovascular, most of the time you see delayed paraplegia more than you see immediate paraplegia. So this is also a difference between endo and open repair. Okay? So in endovascular, the risk factor, as you said, the links of the thoracic aorta we cover. What are the risk factors? I said subclavian occlusion or internal iliac artery occlusion without bypass. Okay? What else?
Longer coverage.
Correct. And AAA repair. If he has a AAA repair because you have a lot of lumbars already closed also, this may consider a high risk for spinal cord ischemia. Okay? So for spinal cord ischemia, so how would do we do it preoperatively or postoperatively?
In endovascular, preoperatively, you can embolize to adapt.
How you do embolization to the lumbars?
To the lumbars, staged.
Yeah, no, nobody. I mean, you can do that, but nobody proves this really increased chance or decreased chance of spinal cord ischemia. But my question, if you're going to put a drain, because the only thing we have for sure that decrease spinal cord ischemia or paraplegia is a spinal cord, correct? This is the only one we have. All other things we can think about it is helpful. The cardiac output, the oxygenation, hemoglobin, I think help. But the only thing we have for sure that decrease or prevent or decrease chance of paraplegia either after open or endovascular is a spinal cord drainage. Okay, why the spinal drain decrease the spinal cord ischemia?
Because you decrease the spinal pressure, so the perfusion.
Yeah, but why spinal pressure decrease the incidence of spinal cord ischemia?
Because the pressure will be higher than in the spinal canal.
Okay. What's the formula? You know what the
Usually
formula?
will be higher.
The formula? The flow, the spinal cord flow. The flow to the spinal cord equal to what? The mean arterial pressure
minus intracranial pressure.
Spinal cord pressure, صح? The flow to the spine depends on mean arterial pressure minus the spinal pressure, spinal cord pressure. Okay? So decrease spinal cord pressure or increase mean arterial pressure will increase your flow. This is the way how it works. All right? Because this formula. Flow equal to mean arterial pressure minus spinal pressure or spinal cord pressure. So increase mean arterial pressure or decrease it. This will help you to increase flow to the. This is the way it works. The flow to the spinal cord and decrease the chance of paraplegia. So the question is that do you do it preoperatively, prophylactically, or you do it after patient wake up if he develop any symptoms?
Recent evidence says selective postoperative is as equal as preoperative.
Correct. So it's better to some people to how you decide which way to do it.
The symptoms, the risk factors you're anticipating.
No, not really. It depends on Ahmed on your setting. Okay. Like if you have a hospital where they can do like spinal cord ischemia, like an emergency, because the patient wake up and he has a paraplegia, and you don't have a spinal cord drainage, you have to drain it right away because like a compartment syndrome, the longer you wait, the less chance that he will recover from his paraplegia. So it has to be done as an emergency. So if you are working in a hospital where you can do a spinal drainage like an emergency middle of the night, then I may wait until after he wake up and then I'll decide. But if you work in a setting in a hospital where putting spinal drainage takes hours and hours, and maybe the guy is not here, you have to come from different place, then it's better to do it preoperatively to be on the safe side. Okay? This is the way how you decide. But in general, as you said, it's no different between preoperatively and postoperatively, but it should be done as an emergency. You cannot wait, hours. And don't get MRI. I see some people, patient after surgery get paraplegia sitting for MRI. This is useless. You don't need MRI to diagnose spinal cord ischemia. It's a clinical diagnosis. The moment you see patient develop a paraplegia, if he has a drain, you have to be sure it's working because sometimes it's kink, and this is very common. So the first thing I check is working or not. If it's working, then you have to increase your main arterial pressure because will help with the flow, may increase blood pressure, increase your oxygenation, keep it more than 95, and be sure the hemoglobin more than 9 because you need to get oxygenation to the spine. Okay. If there's no drain, then you have to do a drain as soon as possible, and then you have to decrease the pressure. If he has a symptom, you just open to the gravity. You don't worry about it. It has to be less than 5. If there's no symptom, just prophylactic, you keep it less than 10. But if anytime he develop any symptoms, usually tell the nurse, anytime you develop a nurse, just open to gravity and then call you. Don't wait until you come. The moment patient develop paraplegia, even has a spinal cord drainage, ask her to open to the gravity, get the pressure as low as possible, and then they call you. But last thing, don't drain more than 20 cc per hour because you may get herniation. So you have to be careful. So you drain, but not too much. You should not go more than 20, 25 cc per hour because you may get herniation. Okay. I think that's all about any question about spinal cord ischemia because this is very important topics and this is the most devastating complications after TEVAR, after sarcoplasmic aortic aneurysm, either open or endovascular. If you do a spinal drainage, leave it at least for 2 days. You don't put them and come next day after TEVAR or branch or BVAR. Next day, patient doing fine, you take the drain out. This is wrong because, as I said, an endovascular delay paraplegia is more common than open. So you have to keep it at least for 2 or 3 days. So don't take it early. Even patients doing fine after procedure, I will keep it at least for 2 or 3 days. Or most of it, they say 3 days, you have to leave it. Then you take it out. The last thing is that about do it prophylactic or not. If you think the patient will stay intubated, then better to do it prophylactic because it's very hard to assess the patient after surgery if he's going to stay intubated. And most of this major surgery, the patient going to stay intubated till next day. So the reason why it's always better to put a prophylactic. Why we don't do prophylactic for everyone? Because spinal cord ischemia has its own complications. You can get bleeding. I saw one case where a patient get paraplegia from the spinal drainage because he developed a bleeding around the spinal cord and hematoma which compresses the cord and he ended with a paraplegia, but it was temporary. But what I try to say is that spinal cord drainage is not also without complications. So you have to be very careful when you decide to use it or not. All right. Any questions?
Yes, Dr. Samer, is there any specific level you will put the spinal drainage? Like if you are doing TEVAR, you will put it like high in the thoracic or there is no difference?
There's no difference really where you put it because all spinal cord is one. The only thing is that the nurse, when you go to ICU, you have to write very clear, please zero the drain to the level of the spine because the nurse in the ICU, they got used to zero any line to the level of the heart because all central lines, arterial line, central line, all zero to the heart. So if you tell them zero, then the nurse will go on zero to the level of the heart, which is very high. So you have to write very careful, very clearly. Please zero the spinal drainage to the level of the spine. Okay. And the same during the procedure. Look at the anesthesia. Go to the anesthesiologist and be sure he level it at the level of the spine. Okay. All right. So let's go to this question now. Who was that? Ahmed?
Yes, please. Coronary artery disease, I don't think this is related. Diabetes, I did not read before it was associated with this.
Correct, yeah.
Carotid occlusive disease, no. But subclavian, maybe. COPD, not, I don't think so.
Yeah.
But chronic kidney disease is very well known.
Yeah. You see, I was when I wrote this question, I thought they're going to put one of these, like, the links of the state of a cover is going to put like internal iliac occlusion. They're going to put like subclavian artery occlusion. I was not expecting to any of these one, but you're right. It's only one paper where they look at that. And one of the major risk factors they found it is, I don't know why, but they found that chronic kidney disease is associated with the increased risk of spinal cord ischemia. But what's the mechanism? I don't know. I know if somebody else knows, but I don't know why, but this is what they found. Yeah. All right, so it's a good question. Where are now? Are we there? 40 is the last question. Who gave it the last question? Let's go to Osama.
Yes.
Osama, I want to take last question.
Okay. Yes. 65-year-old patient receive optimal medical management for uncomplicated type B aortic dissection on index hospitalization. Which of the following is the most likely outcome for the patient during follow-up?
Okay, so what he's telling you is that if you're uncomplicated type B aortic dissection, correct?
Yes.
And we follow him, we decide not to do them because it's uncomplicated. What is going to happen? What is the most thing we worry about in the future when we follow up this patient? What most things could happen to this patient? Let's go through them. Stroke.
Yes, stroke. But
Next,
this
pulse,
likely
lumen.
to be
Mm-hmm.
forced lumen thrombosis.
They said the most common. All could happen. Yes, you can get forced lumen, but what is the most likely outcome? They want the outcome. Yeah, if you follow up these patients, and this is the reason why we have still now a lot of controversy about uncomplicated type B aortic dissection. You know why we have a lot of controversy? Because D, aneurysm degeneration, right? Because the majority is about more than 40 or 50%, they develop an aneurysm degeneration later on. So people, they argue, say, why just go and do it now? Don't wait, because if you follow up this patient, is the majority, they will develop or aneurysm degeneration. About 40-50%, they will need interventions. Where some people, they said, no, let's wait until aneurysm happen, then we'll do it, because only 50%, we can say 50%, TVAR. But some people, they argue, if you do TVAR early, you have better remodeling than if you do it later on, because intima still, dissection is still soft, so you have better remodeling than if you do it later on, where you already, the intima become very thick. So you can argue both ways. But this is the reason why all this argument, because unfortunately, when we follow them, the majority will develop aneurysm in the futures. And again, this is the reason why we do them. So why we don't do TVAR for all of them, and we get rid of these problems? Some people say, okay, 50% is good. Let's do that to all of them, because TVAR has its own complications. Like what? What's the major, most common complication after TVAR, which is that could be fatal?
Retrograde dissection?
Yes, retrograde type A dissection, right?
Yes.
So you may put patient on the fatal outcome. And I think I saw at least 2 or 3 cases, especially with dissection, I think I saw 2 or 3 cases of retrograde dissection, patient died. So it is. So that is why some people say no, we should not do it like routinely, because TEVAR is not like free of complication. And the problem is complication is fatal. You know, to get dissection. I mean, most of the time patient cannot make it. The reason why people are against it, you know. People with it, they said we have better remodeling because type A, the real dissection is very low. So you can argue both ways, but this is the reason why we still have an argument about this ankylosing type B aortic dissection. But now you can understand what is grow, which cone and brown with repair of that ankylosing type B aortic dissection. Okay.
Yes.
So the answer will be.
I think for false limb thrombosis, because that yes, because the other retrograde dissection is mentioned in the question that patient is receiving optimal medical management. Aneurysm degeneration, as you mentioned, Dr. Samer, there is debate about it. And rupture with the optimal medical management, the outcome will not be the rupture. So I think the right answer is.
Right, because what I mean, look at the numbers. Like if you follow them up, what the chance to get stroke is very low. False domain thrombosis is very low. Most of the time you have to do something for that. Retrograde dissection, maybe 1 or 2%. It's very low. Aneurysm dissection talk about 40-50%. Rupture could happen, but I think it's about 5%. So you see, so they want what is the most likely. So all could happen. I'm not saying not, but the most likely outcome could happen is aneurysm degeneration. Okay. All right. I think we're done with the aortic. I think it's the last question. So we still have like 5-10 minutes. We can. Anybody has any question about anything in the aorta? Any aneurysm dissection? Any questions? Yes, please.
Yes, when you do open thoracic aortic aneurysm repair, you said you cut
thoracic
the
or thoracoabdominal? Thoracic or thoracoabdominal?
Yeah, thoracic. When you cut the ligamentum arteriosum.
Yes.
Do you need to ligate it? Do you need to?
No. It's just a fibrotic tissue. It's fibrotic. You don't see ligament really. It's just fibrotic tissue. You just cut it, but you have to cut it because you're going to see that the pulmonary artery, attached to the arch. So you have to cut this tissue. It's not like it's already occluded, so you just cut it. No, you don't have to ligate it.
Is there any chance to find it patent or open?
You should do it before surgery. If you don't want to find during the surgery. No. It's usually it's closed right away. I mean, if it's open, then he has symptoms. I mean, and you can see the CAT scan. And I don't think they can reach to the adult life if it's open, because this mixed arterial with a venous system. Because pulmonary artery is a venous, and this is the other one is arterial. So this is a large fistula. So you have to close it. You cannot leave it. I mean, you can live with it, but most of they stay open. They close it. They don't leave it open. So during surgery will not be. No, will not be. So don't worry, just cut it. But don't cut the nerves. Be careful with the nerves. You have to look at the nerves and find it. Other question? Even for infrarenal aortic aneurysm, guys, any questions? Dissection, infrarenal, juxtarenals, EVAR, TEVAR?
Hi. With the dissection, let me just.
I'm sorry, you are here.
That's okay. Yeah, with the dissection, just have a couple of things. The new SVS CTS guideline, or not guideline, the classification. There's a new classification for dissection. So now, in terms of the type B dissection is divided into complicated and non-complicated, like Dr. Samer said. So the definition is very important to know what's complicated and what's not complicated. So the easiest way I found it to be very helpful is what's non-complicated type B dissection is. So that's means type B dissection without rupture, without malperfusion, and without high-risk features. So on the high-risk features now, we fix them. That's an indication to fix type B dissection in subacute stage, a week or two later. So this is the most important one, is pain, and then the second one is basically radiographic, but they are clinical, which is mainly pain and the size of the aneurysm. So they are radiographic, and then there is also there is a clinical, which is really the most important thing is the pain, and then radiographic malperfusion, radiographic malperfusion, such as very small true lumen, basically, and or big size of the aneurysm. These has to be fixed basically in the acute stage. If you have acute malperfusion, you fix it right away, immediately. But if you have a mesenteric ischemia or you have a leg ischemia, you fix it right away.
That's true.
Sorry, Doctor.
But go ahead.
Yeah. What do you mean by radiological high risk feature? Like if the dissection is extended to the one of the visceral, but the patient is asymptomatic.
Well, if they're having pain, that's not asymptomatic, right? So high risk patient, and if the patient has the radiological high risk features are designed by this society. You know, these include, like I said, very complex dissection with a obliteration of the false lumen, and these they have to be fixed according to the new classification. So you have a very small, tiny false lumen, or you have a large aneurysm more than 4 cm, then this needs to be treated right away. Because like Dr. Samer said, there's about 40% rupture rate in 5 years, and when you treat when you treat DIP dissection with medical therapy alone. So
That's true. But he's talking about radiological feature. You know about them. We talked about before about like the tear size, you know, the aneurysm size, the false lumen size, how many entry size. It's all radiological features.
Yes, Dr. Samer. Is, for example, if the false
What's your
lumen
question?
extended to the, for example, renal artery,
Doesn't matter.
like
Is any
dynamic,
malperfusion or no?
yeah, like dynamic obstruction, but he's not having malperfusion. Is this considered as a high risk radiological feature also, or no?
No.
yeah,
You're
if
confusing.
you have a visceral
Yeah.
I think so. What do you think, Dr. Sam? I think so personally, but
No, I'm saying this is now become complicated. I mean, if you have a dynamic obstruction, that means renal is a creatinine going up, or say like severe hypertension, or creatinine went up, or the kidney function started to deteriorate. This is asymptomatic. This is complicated. It's not uncomplicated. But if you just see dissection to the renal and patients completely asymptomatics from the renal standpoint, this is not a radiologic. It's not a risk factor.
so I can put on the I will put on the website the high risk
Yeah.
features. So the
Yeah.
high risk features are refractory pain, refractory hypertension, readmission. So if you have somebody, these are clinical high risk features. So if you have somebody with
Right.
comes in with pain that you can't control, or hypertension that you cannot control,
Right.
and if this patient came a week ago and he comes back again, this high risk feature
Right.
clinical. Then the second set of high risk features are radiographic or radiologic. So if the aortic diameter more than 40 cm or 40 millimeter or 4 cm, radiologic only malperfusion. What Dr. Samer was referring about right now, if you have dynamic obstruction of a visceral vessel or obliterated true lumen, then that's an indication to fix. This is not an indication to come up in the middle of the night and fix. You can cool them down for a week or so, and then you can go ahead and do it. And the other one is entry tear in the lesser curve as well. This is considered a high risk feature, radiographic, and bloody pleural effusion also. Sometimes you can have a transudate, basically bloody transudate. If you have left pleural effusion, that's also an indication. That's according to the newer classification, and that's what people go by right now, in terms of type B dissection. So
I agree with that. Yes. See, this all risk factor. Hamad mentioned them. But the only thing, guys, I prefer to put the pain and uncontrolled blood pressure out of this risk factor, because risk factor is a controversial. Some people they said, okay, we're not going to go with it. Some people they agree with them. But when you have a pain or frankly blood pressure, you can control it, or pain not control. You send him and he came back with a pain. This is, I think, it's complicated type B. It's not uncomplicated. It's not uncomplicated anymore. It's complicated, so it has to be fixed. So it's not like an area you can negotiate around. So uncontrolled blood pressure, uncontrolled pain has to be fixed. It's like it's a complicated. But the other risk factor Muhammad mentioned, yes. I mean, it's most people they will fix it. But some people say, okay, I don't believe in it. It's okay. But pain and not controlled blood pressure, you have to fix it, because otherwise it will rupture. Sahih, Muhammad?
Yes, absolutely. Yes, absolutely. You're correct.
Yeah.
So at
I
least
mean, pain and blood pressure is very, very, very bad. I mean, it's very bad sign. I mean, you have to fix it, and you cannot wait for 2 weeks. You have to fix it right away. I mean, you know.
yeah, and also there is a difference between, you know, when you treat these patients hyperacutely, your chances of getting type A dissection is higher than
Mhm.
when you cool these patients down for a week or two and then come back. So that's why, you know, we still need to treat these with the stent, but you can wait on those patients a week or two or maybe a few days. And you know, the only time you need to do treatment right away is when you have true malperfusion or rupture.
Yeah, that's true. Okay. Any other question, guys? Anybody want to add anything else?
دكتور the duration
Please.
of يعني to control the pain and hypertension. يعني for example, newly diagnosed aortic dissection in ICU and they start on analgesia and antihypertensive. After how long? يعني مثلا 1 day, 2 days, I will wait if there is no improvement to go during the acute phase, or we should go out this acute after 14 days.
If they don't get better, you go through the acute phase. You bite the bullet and you go. But you know, you try to control their pain with analgesics, you know, blood pressure with drips. There are multiple blood pressure drips that we can use nowadays. It's almost impossible not to control somebody blood pressure, you know, in the hospital now, because there are so many things we can use. And pain also, you can control the pain. So that would lead to essentially, you know, we can buy a week on these patients. Usually, if they stay in house, we can buy a week easy on anybody. Okay.
Yeah, I agree with Muhammad. Yeah, I mean, it's always when they tell you it's not controlled, they're not doing their job really. Because no way you cannot control blood pressure. You have a lot of drips now. You can bring the blood pressure very low. The moment the blood pressure go down, the pain will go down. But to answer your questions, you know, like if you do 1 day, 2 days, 3 days, and still in pain, and for some reason they cannot control it, then you have to go and bite a bullet and go right away because I think he's going to rupture if you don't do it. But again, this is very rare because most of the time you can control it, you know. And if it's not controlled, I don't think they are doing their job. But again, if you are living in, you're like in a small hospital, you know, in rural area, and they're not the ICU is not very skillful, and you come after 2 days, 3 days, especially a lot of pain, not blood pressure, they cannot control it, then to be on safe side, I'll go and put a TVAR. Okay.
Yes, Dr. Samer.
Mm-hmm.
How do you do measurement for type B dissection? If there is, for example, you have a patient who's having 4 centimeter aneurysmal changes with type B dissection, acute in the subacute phase, and you want to do
Mm-hmm.
TVAR. It is not recommended to oversize more than 10%. But how do you size it? Based on, do you go proximal to the left subclavian and measure there and consider it as your baseline, or?
There's a question. Where is your landing zone? How do you decide which one is your landing zone?
So the
Yeah,
Let's
landing,
say the entry. Let's say that the recession start on subclavian, but the entry site like about 4 centimeter from subclavian, the entry site. So where is your landing zone?
I will land at the subclavian.
Level of subclavian.
Yeah.
Because you measure 3 centimeter there, because the entry is 3 centimeter from the subclavian. Right?
Yeah, if I have like 3 centimeter, if the entry is distal around 3 centimeter from the left subclavian.
Yeah,
I
but the
will land.
aneurysm starts at subclavian, but the dissection starts because it's go backwards, you know?
Yes.
The entry site
Yes.
is 3 centimeter, but go backward to subclavian, then stop because subclavian stop it. So this is my question: is that the aneurysm, the dissection went backward to subclavian and stopped, but the entry site about 3 centimeters. So where is your landing zone? Where are you going to start your landing zone? Very
I will
important
consider
question.
it. I will consider it as aneurysm. I will try to get.
There's no aneurysm,
minimum.
just dissection. There's no aneurysm there.
I will land at the subclavian.
Just distal to subclavian.
Yes.
Then you end with type A dissection. Yeah, this is what I'm trying to say. You cannot, even with the lumen thrombose, you cannot land in the area of dissection because this is the area where you're going to do the check again. You have to go to the normal aorta. Doesn't matter where the tear started. As far you have a dissection area, even if that falls lumen thrombosed or like intramural hematoma, you cannot land in this area. You have to go to the normal aorta. So in this case, I have to, count at least 2 centimeters proximal to subclavian. And then this will be my landing zone. So my landing zone always has to be normal aorta in the arch. And then your size depends on the arch. So this is your landing zone. When again, no way you can to land inside the dissection area, even if the first lumen thrombose, even if that tear is too down, it doesn't matter. You have always start in the healthy aorta. So this is how you decide it. The question about distal will be collapse. This is the problem, the distal. Then this is controversial, Some people, they use a tapered one. At least you can decrease it. Some people, they use the same size because they use what's called stabilized technique. But the problem is that how long you need to cover? It's the second question. How long you need to cover? Do you know, Barra, because you are the one asking question? How long you cover?
والله I don't know. Usually just cover يعني enough segment.
But the dissection going all the way down, to the iliac.
You don't need to go down to the iliac. You just cover around the anterior, proximal, and distal.
No, just a second. What do you mean proximal distal? I mean, you just see proximal. There's multiple tear there, like around SMA, around renals, a lot of entry there. Infrarenal has a lot of entry there. So how much you going to cover?
I will cover only the proximal one.
Yeah, but how long? 10, 20, 30, 40?
I don't know.
What's 10? You don't know. It's good. Usually the minimum should be at least 20. The minimum you need to cover, okay? Some people, they cover all the way down to the celiac, okay? This is plus and minus. They said if you have an aneurysm, you have to cover the area of aneurysm. So 3 things. If you don't have aneurysm, just a dissection, and you do it like for pain or for something else, then you cover at least 2 centimeters, 20 or more, but at least 20. You cannot go less than 20. It's too short. So it should be at least 20 or more. Some people, they go all the way down to the celiac. If you go to the celiac, it's better. You have better remodeling, but the problem, higher chance of paraplegia. So you have to think about what is the best. So you can think about, Cohen and Brown for this, for these situations. The more you cover is better, but high chance of paraplegia. So you have to decide depending how it looks. If it's aneurysm, then you have to cover the whole aneurysm area until you get to the area where you have a dissection, but the aorta is not dilated. This is the way how you decide the length. The distal lumen is very hard to decide because most of it's collapsed. Some people, they go with the total. So it's very hard. Better to use a tapered one, but the problem with the 20, they don't have a tapered. Tapered comes with 150. 150 is too short. So we end using just a regular one, straight one, at least 20 or more. But in general, the distal is just an estimate, but the proximal, you just measure the aorta and you size 0 to 10%. And no ballooning, of course. Unless if you decide, you balloon, unless if you decide to use stabilized technique or you put, dissection stent, then you want to expand the true lumen, then you do ballooning.
Dr. Samer, I have a
Muhammad, you
question.
want to add? Yes.
Yeah, sure, sure. So just have a little comment about.
Yeah, how much you cover, Muhammad? Because everyone's
yeah,
different. So how much you decide and to cover?
Well, I cover routinely close to the diaphragm, even a little bit, just right
Go to
before
the celiac. Yeah, some people
And
they do
that's-
that. Yeah.
There's a lot of data that has been shown it's better outcome on remodeling.
Yeah.
The use of dissection
What about
stents.
paraplegia? Don't worry about paraplegia because
I
increased
worry
risk
about
of
paraplegia. So we worry about paraplegia. So
Yeah.
with paraplegia now, there are a whole multitude of things that you can do, management, blood pressure,
Yeah.
hemoglobin,
Yeah.
things like that. You worry about paraplegia, but people doing now thoracoabdominals like staged, but they're not
Right.
even putting drains in these patients, so
Correct.
there's
Yes.
risk, there's
Yeah.
risk, there's always risk with paraplegia with these. But if you want to get the best outcome with dissection, is to cover as distal as possible. And if you see
Yeah.
clearly, like on the CT scan, the the arteries of Adam-Quich or things like that, you just try to put them,
Avoid it.
the graph above. But the closer you go, the better off you are, So and if we can't, what we do in our practice, we put dissection stent. So dissection
Yeah.
stent is not covered; it's open cell, so blood goes through. And what it does is just tacks the flap, the false lumen over time, and you get better remodeling with it. And the stabilized technique is very controversial because you put a balloon and there's risk, but the just putting a dissection stent without ballooning, there are two big trials showed mortality benefit from that. So doing that on these patients with the acute, with the if they have a indication which is a small false lumen or malperfusion or things like that. So, but stabilize when you put a balloon inside. That's a very controversial. We do it, I do
Yeah.
it. It's it's risky sometimes.
Yeah, that's true. Any other question, guys?
Dr.
Doctor,
Samer, one last question.
Yes, please.
We do the landing zone proximal to the anterior tier. There is any specific distance in the normal aorta? So let's say that the anterior tier is 4 centimeters from the subclavian. So we will go to the normal aorta for the proximal. There is any specific distance should be in the normal aorta?
Okay, let's go to the questions. First, you start measuring from the area where there's no dissections. Don't worry about the tear. Tear is not I don't measure from the tear. I measure where is the area we have a dissection. So the dissection start from subclavian. Then I'm going to start my landing zone from subclavian proximal. I'm not going to start from where the proximal entry tear. Okay. So my measure will be from subclavian proximal. Okay. Always teaching you need 2 centimeters. But in dissection, you may compromise it, depending how much you cover. Like if I can get away with I don't have to cover left subcommon carotid. If I go 1.5 centimeter, I think it would be acceptable because this is different from aneurysms. This is just mainly supporting the aorta. It's not like you're looking for endotype 1 endo leak. So then I think 1.5 centimeter I will accept it for dissection. If I have to go 2 centimeter to cover left common carotid. If I have 2 centimeter between the left common carotid and subclavian, then it'd be the best to get 2 centimeter. If I cannot, if I get only 1.5, I think it'd be reasonable. If less than that, I think it become too short. Then I have to go and cover also left common carotid artery. But this will be. Muhammad, how much you need length for dissection?
It's a graft dependent, So if you're using, so you have to follow the IFU of the graft. You're absolutely right that you have to go the healthy aorta. And sometimes, in some cases, and maybe that's off records, I don't know. We would be, if somebody had type A dissection and the arch is involved and the arch is not aneurysmal and they have malperfusion, we would still put a stent, go by the landing tear, by the tear. But the general principles is to go to healthy aorta for sure. But in some cases, you're okay to do leave the arch alone because the arch is so much. It's very complicated to fix if it's not involved. And do the descending aorta. But as far as for landing zone is a graft dependent. So Gore, 1.5 cm. Usually that's the most landing zone that we use. But it's a graft dependent basically. So
that's true. For this arch, yes, I agree. If you do it after type B, after you fix the ascending aorta, and then you have a dissection of the arch, yes, I agree. You can land in this dissection. And the reason why you will not get type A dissection anymore because ascending aorta is already fixed, So
right.
You can't get any more. You can make it leak, no problem, but you're not going to get type A dissections. But so the only time you're going to see arch dissection if you have type A after type A repair. So in this scenario, yes, I think you can land in the area. But if you have a pure type B dissections, I prefer to go to the normal aorta.
Absolutely, yeah. Absolutely, yeah. That's absolutely that's actually a better way to say it. So yeah, definitely.
Yeah. All right. Any other questions?
yes, Doctor.
Yes.
Doctor,
Go ahead.
any difference in the length of coverage between traumatic dissection and other dissection?
Good question. You mean traumatic dissection versus regular dissections?
Yes.
Yes. No, traumatic dissection is usually short. So usually we end with only 110 centimeters. That's more than enough. The second thing in trisection, you can cover subclavian without bypass. It's 100%. Yeah, not 100%, but majority of the time is okay, unless you have a large vertebra coming from the left subclavian. So in trauma, you usually need a short one. And second thing, the landing zone, it's enough. 10 millimeters is enough for trauma. So you don't need like 1.5 or 2 centimeters in trauma, because again, you're just supporting the aorta. So even some papers, they showed 5 millimeters is enough, but I think it's too short. So at least you need 10 millimeters. But most studies showed 10 millimeters is enough for landing zone for trauma. So in trauma, you just use like 100 centimeters, short one, with 1 centimeter landing zone will be enough. And the second thing, if you don't have a rupture, it's like, grade 3, when you finish, even if you see some flushing around the aorta, you still some like type 1 endo leak, don't worry about it. This will go away. Because the whole idea from trauma to support the aorta. So don't, if you see like type 1 endo leak, you see some blood go around it, you go and balloon it because you may rupture. I will leave it alone. You do CAT scan after a couple of months, this will be thrombosed. So don't worry about it. Unless you have a free rupture, it's different. Then you have to be sure there's no leak. But if you do it like for type 3, which is the most of the time you do it for type 3, then after you put a TVAR, if you see some mild type A dissection leak or some flushing around it, the graft, because still blood going to around the graft, I will leave it alone. I will not worry about it. Muhammad, what do you think?
I agree with you 100%. This is for trauma, yeah, exactly. So, and a lot of times, with the thoracic cases, you'll end up with leak, and then you scan them again. If the leak is not overt, it will go away, in a month or so.
Why I'm saying that, because I saw a case where not this long time ago, when I came here. So after they finished, they saw a leak, so they put another graft inside, and he ended with the infolding of the graft, and he ended with the graft like infolded because it was very large inside all the graft. And then this patient end with chronic hypertension, and then at the end, I have to go and take it out and put graft there surgically.
Yeah.
So don't put the graft inside the graft. Yeah.
Even with EVARs, that's also the case. I had a recent case where old man, we did a EVAR, regular EVAR. We had type 1A leak, very small, was not small actually, So we set him up to do TAMPI, which is a branch graft, and just I scanned him a couple of days before, just to make sure nothing. I won't be surprised with the case, and his leak has gone away. Now it may come back later. I don't know, but that's the thing is, like, if you don't have a big leak, you follow and you scan him again, and see what happens. So
that's true. Any other question?
Last question, Dr.
Samer.
Okay. That's good. That's good for the people to get this question.
Okay. If we have complicated dissection and we elected to do for him TVAR with coverage of 20 cm, are we going to do bypass after procedure or not?
Good questions. Go ahead.
No, it depends. Bypass, like, what do you mean? Which bypass? The coracoid bypass, or?
Yes, carotid subclavian.
So it depends. If it's emergency, if you have malperfusion emergency, you don't have to, and you have a dominant opposite side, a dominant vertebral, you don't have to do it. But if it's not emergency, then you probably want to do the bypass. We do the bypass before the TVAR because the covering subclavian is one of the risk factors of getting paraplegia. So
I agree with that.
Dr. Samer, I have a question.
No, let's finish this question. Yes, I mean, if you do it, guys, for trauma, it's not an important, as we said. But when you do it for that, even if you put a short one, 20 centimeters, I think you need to do subclavian bypass, not because this time, because later on you're going to go back and you put more stent, because this dissection is we do it on stages. That later on you get more aneurysms, going to repair more. So you have always from now, you have to be ready for that. So anytime I do dissection, always I do cut subclavian. If I have to close subclavian, I do cut it subclavian bypass, even if I put a short one, only 20 centimeters, because I'm my mind that I need to go later on and put more extension, more stent, I'll be covering more intercostal. So you have to be prepared to decrease chance of paraplegia. So the answer, yes. But as Muhammad said, in an emergency, no. You do, of course, TVAR first, then you do bypass later on. But it's not an emergency. I prefer also do a bypass first and then TVAR, all do the same time.
Sir Samer, I have a question.
Mhm.
In a trauma patient, you don't have a proper landing zone. Would you rather cover the subclavian completely or partially, if it is enough as a landing zone?
Well, I cover it partially. But let me tell you something different also. Sometimes I cover it partially, even if I have a landing zone. Like let's say subclavian is about centimeter away, transection about centimeter away from subclavian. Sometimes even though I cover subclavian, you know why? Because the arch curve, you have to look at the curve. You cannot put the aneurysm stacking up at the aneurysm at the curve of the arch, because otherwise you end with a bird peak and then end with chronic hypertension. So you have to see also how the TVAR will land. So if the TVAR is going to stuck at the middle to not to cover subclavian, it's going to stuck up in the middle of arch, then no, I will go take the arch, take the curve. Even if I have to cover subclavian, I will take the curve just to make the graft taking the curve and not picking inside middle of the arch. This is very important to think about, you know. So don't only look at the landing zone and how distant. You have to be sure that the graft taking the curve, because otherwise the graft will be sticking up and you end with the chronic hypertension.
Yeah, and in the future, this question would probably be now what I do for these. Most of these we do a branched subclavian.
Subclavian,
Yeah,
from
and
Gore.
you know, once you get a hang of it, it's very quickly. You know, you can do it in 40 minutes. And there are two on the markets now. The Cook, there's one, but it's not available in the United States. And then Gore, there's a Gore TBE branch, which is a straightforward case. You know, once you do a few of them. So that's probably gonna be, you know, already our fellows complain about doing less rather subclavian bypass than before because of this. You know. Right.
Yeah, it's a good one. Yeah, that's true.
Yeah.
Any more
Dr. Jabri,
questions?
you consider using this branch and even in trauma?
In trauma, I've done a
Rather than-
few. I've done, I don't know, 3 or 4 cases at least, you know, of this. Once you get a hang of it, it's really quick, you know, so to do it. It's not very hard to do. You know, so
As I said, Ahmed, sometimes you don't do it because subclavian, because the curve, you know. So you
because
have
the
to be
curve,
the
exactly.
takes the
Yeah.
curve because you and the reason why you need to take this one, not because you subclavian. Yes, you can cover subclavian, but if you cover sometimes the graft was sticking up, especially
Right.
in young people, because the arch is very curved, especially in young people. This is where you get the trauma in young people.
Yes.
So
yes.
the reason why you do this one, so you can take the curve, so you don't have end with a bird peak, you know.
Exactly. So
Any
Another
other
question.
Yes.
Dr. Samer, when you measure the landing, the size that you need, would you really trust the center line measurements in a trauma settings and sizing?
Okay, two things. First, in trauma, you don't trust even the diameters because patient have to know when the CT scan done. I think it's very important to know when the CT is done. Was patient hypotensive or not? Because this will change your sizing. Of course, if you are working in tertiary care hospital, some people use an IFAS, which is more accurate, you know, during the procedure to make a sizing. Because sometimes if you do a sizing on the CT scan, a CT scan done where patient's hypotensive, you are like, you know, you are undersizing the graft. These are problems, you know. So it's very important when you do a sizing to know how blood pressure patient at that time, or if you have an IVAS, to use an IVAS. What was the question? Sorry. So the links. The links, no, central line for the neck in general, not for trauma. I'm talking in general when aneurysm. When you talk about the neck length, it has to be the inner curvatures. So when you measure the length, you have to move your center line to the inner curvature. And this is what you need 2 centimeters for the aneurysm from the inner curvature. If you take central line, you're losing a couple of millimeters. But the length of the device, you go to outer curvature because the length will take the outer curvature. If you take a center line, the length of the graph will be short. So again, for the length of the graph, I will take the outer curvature. For the length of the neck, I'll take the inner curvature, not the central line. To answer your question.
Does it matter choosing certain product or there's a new Gore conformable rather than the Meditronics one in trauma?
No, I don't think so. I mean, all the new devices now are very flexible. I don't think it's major difference. I think it's all like marketing, points. I don't think it's any major difference. Muhammad has betters. But I don't think it's all marketing. Tell you this one's better, less curve, this is more comfortable. I don't think so. I think the majority now, the new devices are very flexible, very similar. So I don't think so. Muhammad, what do you think, Muhammad?
Yeah, I think so. Although for steep arches, for type 3 arches, in my experience, the best grafts to use either Gore conformable or Bolton graft. Although Bolton graft has a larger sheath because they confirm better, but the old graft, like you said, for trauma, definitely all of them are the same.
Yeah. Okay. Any other question? All right, great. Thank you, Muhammad. I'm glad you were with us today to answer all the questions from the fellows. So finish with aortoiliac. The question, what do you want to do next? You want to go to peripheral or you want to go to the AV axis? What do you prefer, guys? Just answer that on the chat group. What do you want us to start? Because we're done with the cardio, we're done with aortoiliac. So next step, either we'd have to do with the peripheral, lower extremities, or we have to go with AV axis. These are the two most common, scenario we see in our practice. All right, thank you, everyone. Thank you, Muhammad, again, for joining us. And thank you, everyone. And we'll see you next week, hopefully. Take care. Bye-bye.